Thank you and welcome today to another Safer Everyday event. Welcome to those who are on Teams who have joined us and to those in the room at the Gateway Club. Today we're going to have two groups presenting, one from an acute setting, Victoria Wing, and the other from the older adult community mental health teams, and they're going to be sharing their journey to achieve what is known as a blue SCAPE status. Now, some people may not know what SCAPE is, and SCAPE stands for Safe, Clean and Personal Every Time. It is an audit process that we introduced in 2015 throughout HSC, and it was brought over from a trip to Salford at the time, when we were going through, HSC were going through quite a difficult process. We'd become under the spotlight in various circumstances around maternity services. We took the opportunity to go and learn from an area who had, by CQC standards, been considered to be in special measures and were not performing great, and that was Salford. So we went to Salford because by the time we got to Salford, they were then considered to be excellent and performing really well from a CQC perspective. So we wanted to see, how did they do that? What things did they implement to make those changes? And one big fundamental part of that was to introduce SCAPE. It was originally focused around nursing care delivery. But over the years, we've tweaked that and embraced basically anybody, any service delivery. So therapy groups, the doctors themselves, the nursing care, and obviously fundamentally our HCAs and support workers who, without them, we would not be able to do half of what we do. So we've broadened it out, and it has gone on a big journey in HSC. Started off in the acute setting and is now not everywhere, but is still in a transitional process. In 2018 and 2019, adult disability services and mental health services came on board. So acute have been doing it for the longest period of time, and many of their areas have achieved blue SCAPE status. Victoria Wing and another area who sadly aren't able to present today, but another area, have also recently achieved their blue SCAPE status in their audits that will have completed last year. So we're going to hear about theirs, and their presentation is first. So I'm going to hand over to the team of Victoria Wing who've come along, and that is Jane Baker, their ward sister, Evie Walter, one of the staff nurses, and Eve Dial, one of the senior staff nurses. So over to you.
Okay, so as you're probably all aware, we're the private unit within the PEH, although we do take the overflow for the other wards when they're full. We have 19 side rooms where we nurse all different types of patients. So as you come into the ward, you've probably all seen these are transparency boards. It's about being open, transparent and honest. Anybody can read this board when we've had falls or infections, what we're striving to do, and also our audits are down in the corner. So when I first went to Victoria Wing six years ago, they hadn't had a green SCAPE, they'd only had orange. And from the area where I'd worked before, I took those skills with me, and we looked at breaking down the domains, giving each person ownership of a domain and pulling it in with a linked nurse role at the same time. I put it out there and I gave everybody the chance for what they were interested in, and it came back and it's actually quite positive, and a lot of the roles now we've actually got 2 staff members for each role. The other one. So there's 15 domains to the SCAPE. We've divided these between the 3 of us, and we're just going to talk you through each domain. So if I go through domains 1 to 4, about the organisation and management of the clinical area, to ensure everything's kept up to date, we do regular ward meetings monthly. If we can't manage them on a month, I'll send out a monthly update to all the staff just to keep them aware of what's going on. Safeguarding, we've now got 2 level 3 qualified safeguard leads within the work area, and the rest of the staff are level 1 trained. The pain management, is done by the clinical nurse specialist who visits the ward every day. We've also got 2 link nurses for pain management. And patient safety, although we have a link nurse for patient safety, we're all involved in patient safety with the equipment that we need, because working inside rooms where we can't observe the patients obviously makes the job quite a bit more difficult, really. And I'm going to hand over now to Eve.
Yes, I'm taking the domain 5 and 9, so environmental safety. As we all know, that the ward setup is very challenging to nurse patient, really. But we just to make sure that the staff are within, will manage within our scope, ensuring that the safety and in case of there's an emergency is visible, and we also manage, and the staff are trained to do this one. The second one is, the 6th one is nutrition and hydration. So this is evident that the service users been reassessed every week, just to make sure, and also before we're incorporating the mass score, and we also working closely with the dietitian if we need be. And end of life care. So we have 2 link nurses of end of life care, and we just to make sure that this patient, we're ensuring that the 5 priorities of care in dying will be observed, so they be involved. They go with the wishes of the patients, and also we involve the significant others as well to do that. So medicine management, we're working with this alongside with pharmacy, so that we will manage our needs and near and miss when it comes to errors and stuff like that. And if there's anything, we just do some incident reporting. If we need to, and there's any reactions or whatever, we just new reaction to the patient, we just to report it on a yellow card and stuff like that online. And we just to make sure that the patient-centered care as well is a paramount and adhere all the time. So we just to make sure that it's visible to all the patients. We're treating with dignity, respect, and we're incorporating the 6 C's as well. So I'm just going to pass on to Evie.
Hello, I'm Evie. I'm one of the staff nurses. So I'm going to talk about domains 10 to 15. So for tissue viability, we work very closely with the tissue viability nurse services in ensuring that if we have patients come in and they have pressure ulcers of wounds, that we're applying the right dressings, that they're being reviewed regularly, and we are also documenting that on our wound care chart. For elimination, we work very closely with our doctors and our urology team in ensuring that patients are able to pass urine and open their bowels, and if not, we then talk with our other members of the MD team, ensuring that we get patients able to eliminate. Infection control. So this is a very vast area on our ward. It covers hand washing, patients coming into hospital with infections, as we all know, COVID, MRSA, things like that. And we work very closely with our infection control team. And we have 2 link nurses and an HCA are all involved within that, within our team. The NMC Code of Conduct, so everybody on our ward works within the NMC Code of Conduct, and all those areas such as prioritise people, practice effectively, preserve safety and promote professionalism and trust within the hospital. And we're also supported, so within the NMC Code of Conduct, we're also supported during our PIP, and we have regular meetings with our manager. And then dementia, so we work as part of the wider MDT team in ensuring that patients that are admitted to Vic Wing with dementia are cared for safely. We are the ward that has we don't have a ward bay, we are just predominantly side rooms, and sometimes that can be quite challenging in caring with people with dementia, so it's just about ensuring their safety. And if we don't feel it's suitable for someone with dementia to be on our ward, then we do highlight that to the number 1 within the hospital to ensure that they are somewhere where they can be kept safe.
No,
No, it's not changing.
no, you're doing.
Okay, so the link rice roll, once we get there. Stop going.
think it could be because I have somebody on Teams who's got their camera on. Is that causing my problem?
Shouldn't do.
Which sound are you supposed to be on?
You might just have to go to presenter view for the presentation, do it manually and ignore the remote.
Is it doing it now? Right, I'll do it from here then. I don't mind it. Sorry.
Thank you. So, as we've discussed, each domain that we look at for SCAPE is split into a separate domain, and there's usually 2 link nurses involved in that. We do get our HCAs involved as well, so sometimes there's 3. So as part of the link nurse, we're to attend meetings and report back what's been discussed in these meetings. We then print off the minutes and ensure that these are read by the staff on the ward. And then it's also about, we might be involved in updating the paperwork, some of the pathways that we use. I've recently gone to one of the palliative care meetings, and we're going to start the process of looking at our end of life pathway and how we can update that within the hospital. And it's just ensuring that everybody's following the policies and procedures set out by HSC and that we're all working to the standard that we should be.
So, going forward and to maintain these SCAPE standards, first I've got to say it's a whole team effort. Everybody's been involved, right from the top down to the bottom. A lot of our audits are based on our patients' views. We get quite a lot of nice feedback from patients and visitors as well. We facilitate the change as it's needed. So we'll continue to have our monthly meetings where we'll discuss using the format of what, when and how. We support and give feedback, and hopefully anybody that comes forward with ideas and suggestions, we'll go forward with that. We carry out quite a lot of trials. If they work, then we continue using them. If not, then we go back to the drawing board. We facilitate change as needed. At the moment, we are trialling new paperwork to see how that works within our area. And we try and implement all these changes as a team. And hopefully we'll just carry on with our blue status. And thank you for all listening. And are there any questions?
I'm just wondering how you identify somebody with dementia. So if somebody came on shift that didn't know this patient was admitted, how would they know that they had dementia and needed a bit of extra help?
So it should be part of the initial handover, especially if they're coming through from A&E, that this patient has known dementia. If they're a bit confused, then we'll try and place them as close to the nurse's station as possible. They'll be checked a bit more often. We have things called sensor mats within the ward that we can place on chairs and beds, just in case, because you get to know fairly quickly if they're able to call a bell or not.
Yeah.
And things like that, and then if it's overnight in the morning, we'll then hand over to the day staff and they can get assessments and things started.
Just on the back of that, any patient with any cognitive difficulties wears a yellow band on their arm, so they're identified quite quickly, really.
Yeah. Good. Thanks.
Jay, what did you find the hardest thing to consider to strive for the Blue Scape Award?
I don't know really. I think we were well in a position to go for the Blue Scape, I think about 3 years ago, and then COVID hit, and it was keeping everybody positive really through all of that, maintaining the greens through COVID, and of course now we're out the other side, we're in a better position to apply for the Blue Scape.
Do you think the tool is challenging enough?
Yeah, most definitely. Most definitely, yeah. It is, but when you've got a team on side that they take their role seriously, and the domains that they're responsible for, it makes teamwork a lot easier, and it makes maintaining the SCAPE a lot easier.
Because every time the audit takes place, which usually has me a part of that team, we usually find something, not very many actions, but we usually do find some improvement plans that we think we can do, don't we? And you just embrace that really, and in those groups that you sort of talked about, you set to work to achieve those improvements before you're audited again. And yeah, I think Jenny's also in the room. I'm pretty sure Jenny would also be saying that, you know, the work that you've done to sort of configure yourselves as a team approach has really helped embed it. And I think the fact that you knew that approach from your previous experience in another area of the hospital also helped sort of feeding that through. So this is partly why we're doing this session today. Partly it's just to introduce people to it so that people can take away ideas about how they might go about embedding SCAPE if they haven't quite got there yet, and how they might actually start doing it right from the outset, because some areas haven't even got a SCAPE audit yet. So, good.
I'd just like to take the opportunity to congratulate you all. I don't have any questions because I've been throughout the process with you, so I very much know what happened there. And I think that you are one of our finest examples of how SCAPE works. And you just mentioned, Jane, that you're doing more audits now and you have more audits in place. And for me, that's quite relevant, of course, with the role that I have for the organization, because that's what I get from SCAPE. It just makes everyone think how helpful audits can actually be, not only SCAPE audit itself as the internal audit program of the organization, but all the other processes that you are able to implement from that in your service area that will actually get you towards improvement. That's what we all want, and to actually maintain that improvement level and that quality level that we all aim for. So, well done.
Thank you.
Well done.
I think you're led. Oh, another question.
Are the domains, do you choose the domains or are they set? You had your 15...
They're set.
They're set.
Yeah,
Okay.
they're set by the audit team.
Okay, but it's variable. Each team might have different domains depending
They-
on...
They absolutely do vary. There's a core group of set expectations, set standards that we have that I think would seem very reasonable to have across the whole organisation. But in order for a SCAPE audit to be of value, it has to be tailored to look at things that are important to that clinical picture and clinical. Please come sit down. To that clinical picture and that clinical presentation. So, yes, tailor-made with key standards, key domains, but it expands greatly depending on the areas. So yeah. We want it to be very much part and parcel of everyday practice, because there's no point auditing and either having something that says not applicable because I don't do this. Well, you're never going to learn and we're never going to improve, are we, if we're auditing the wrong thing? So it's a really crucial part of the process. And recently we've had St John Ambulance and also GTG have taken on board, and cardiology have, and the hospice is starting. So we've just completed their first audits for cardiology, St John Ambulance and GTG, and they've gone through that process of developing tools with our support that align to the practice that they do, to the Royal Colleges, to whatever guidance and CQC standards are out and about for those areas. So that's the piece of work that is goes before you even get to the day of the audit. But each audit is tailored to suit the needs and suit the areas. Is that it from everybody? Not there. Brilliant. Thank you very much, ladies. Oh no, sorry, I can't see you. Sorry.
What would you recommend is the most important information to have on your transparent board?
Really, it's because it's about being open and transparent. It's nice to have. You have the falls on your board. We've got the MRSA
and the
pressure areas. But as well, what's on that board is like your infection control audit score, so people coming in can see what percentage of score, the ward cleanliness score. But it also has the information of, so if you look at our board at the moment, we've got our lead nurse and then me, then my deputy, and then it goes through our senior staff nurses now. And what I've recently started doing is we get, from Laura Sharp, every month, we get a list of compliments that have come through for the ward. And I now print those off, laminate them, and also put them on the board so visitors and staff can see them then.
Thank you.
Sorry, was there any more? I couldn't see. Sorry, I apologise for that. No more questions? Well, thank you very much, Victoria Wing. Well done in achieving your blue skate status.
Thank you.
Thank you. And next we have the older adult community mental health team, who are going to share how they have embedded SCAPE throughout in order to improve patient safety for the service users that they support.
Good afternoon, everyone. I'm Paul Corcoran, clinical nurse specialist in the older adult mental health team.
Yeah, I'm Neil Graybold, CPN, as in the older adults team, and
Kate Wilson, one of the nurses that works primarily in the memory clinic. I'm taking advantage of the old and sitting down.
And we have two other members here who are just going to introduce themselves, but I don't think they're going to speak as such. But
I'm Sue, I'm the occupational therapist in the team.
And I'm Sarah, I'm one of the new nurses in the team.
Got my oldest one.
oh, Rahul is there, sorry as well. Sorry, Rahul.
Yeah.
I didn't see you sneak in.
he's our consultant psychiatrist.
So yes, we just underwent the SCAPE audit for the second time, and we're fairly new to the process really, because I think mental health were a little bit later to the party of adopting SCAPE, and there were some tweaks that were made specifically for the mental health teams in particular. You know, Safe, Clean and Personal Every Time is the acronym, and it is very much, I think, when it was initially sort of conceived as sort of an audit on clinical environments, and obviously with a mental health team, we're not in a clinical ward environment, we're in people's homes a lot of the time. So the standards are, the core standards are the same, but I think some of them were taken out, and I'll tell you what those were. So just for the aims today, we're going to have a look at the team composition and the key roles of the team. The preparation we did ahead of the SCAPE process, and I must say as well that our manager, Mark Haynes, who was very much involved in it, is still away on leave in the Far East, and so he would have been here today, and he was involved in the prep. We'll talk about the assessment process of SCAPE, the reflections on the process, and then any conclusion and learning points that came out of it. So there's our team there, all very happy. There's one
missing there.
There's one missing. Kirstine wasn't there for the photograph. She's a CPN as well. We've got all the clinicians there, and Rhiannon, our PA, in the front, who is very important to keeping the team ticking along. So yeah, just the makeup of the team. This is our establishment. We have one consultant psychiatrist currently. Rahul, as associate, is stepping up as consultant, and one associate specialist doctor. We've got a team manager, who I said is Mark, who's not here, but has sort of been implementing good processes over the past couple of years since he's been here, and has been very helpful in that regard. He's very much an organisational manager rather than a clinician, but he has a hand in clinical work as well. The nurse specialist is myself. I'm a nurse prescriber, and we have 5 senior nurse practitioners, 4 in post and 1 vacancy. Sue is our occupational therapist. We have Bex, who's our support worker, who is not here, and of course we have Rhiannon as our PA. So we all do similar core work, but we all have little specialties as well.
Overlapping certain areas, and Rhiannon's quite, like you say, holds the team together. She's quite knowledgeable on our service as well.
Yeah, so Sue might do sort of specific occupational therapy work that I wouldn't get involved in or wouldn't be an expert in, and Kay would mainly focus on sort of new memory assessments, and the rest of us can just get stuck in. So next slide, please, Vicky. So we're a multidisciplinary team. We focus on the mental health of older adults aged over 75. So that's recently been changed over the past few years from 65. We're involved in the assessment and diagnosis of dementia through the memory clinic pathway. That's an established diagnostic pathway, and there's no age limit on that. So we've been seeing a lot of younger people coming through, sadly, late 50s, early 60s,
We've actually got the pathways at the front here. If anybody wants a copy of it afterwards, got
Yeah.
5 copies of each.
We
Pretty
can-
much several of them.
You can take a copy. Apart from, we're also involved in the assessment and treatment of behavioural and psychological symptoms in dementia. That's normally in a care home environment. So somebody whose maybe behaviour is a bit unmanageable or trying to express unmet needs, and there's no age limit on that. It depends on if the person has dementia or not. If we're getting involved in somebody who has a functional mental health problem like depression or anxiety, they must be over 75. So there are other teams in Oberlin's who deal with people who are under 75 and don't have dementia. We liaise closely with Totenay Ward, which is our assessment ward, and the Lighthouse wards over here, which are the continuing care, long stay wards. And we also link in with the third sector groups such as Guernsey Alzheimer's Association for carer support and various groups that go on there.
Yeah, Guernsey Alzheimer's Society, and also they have the meetings and various things, outreach things, and they have a little carer services and things that we can utilise.
Okay, next slide. So that's about us. So preparation ahead of SCAPE then. Our team manager, Mark, engaged regularly with the quality and patient safety team to enable the SCAPE process to be cohesive with the KPIs for the team. So, as I said, I mean, the standards were read out on the previous presentation from Vic Wing just then, but there were several ones that are not assessed upon. Where did I put that? My note again. Yeah, so we're not looking at things like pain management, nutrition and hydration, end-of-life care, tissue viability or elimination, because we're not dealing with that sort of person day to day. If they're in a ward environment, yes, of course, and I'm sure Totenay Ward would be assessed on those standards, but we're looking after people who are at home. So the main standards we're looking at are organisation and team management, safeguarding is a big one, person-centred care, medicines management, communication, infection control, and codes of conduct. And in our previous SCAPE audit, we had scored very well in terms of the preparation ahead of SCAPE. So point 2 there, we also liaised closely with the practice development lead and the senior management team to again make sure that the SCAPE standards were fitting for the service that we deliver. And Mark, sort of spoke to us many times about the heart, the idea of this audit is not about sort of being too critical, but it's actually focusing on the fact that, that making sure the care we deliver is safe and the families are supported well, and looking at what works well as well as identifying what improvements need to be made. Thank you. So do anyone else want to read out those ones?
Okay, so I got prepared for SCAPE. The team manager initially got involved, but it's ongoing process anyway. And the personal assistant, just read that again.
Yeah, so we knew that the SCAPE date was going to be on a Tuesday morning, and we had kind of narrowed it down to a certain day or two, a Tuesday or another Tuesday.
Yeah.
So I think once we kind of identified what day it was going to be, that was put into all the practitioners' calendar to make sure that the whole team was there, because it's very easy to sort of have practitioners say, well, I'm seeing somebody that morning, I've booked in an assessment, I can't be there, and then it's only down to 1 or 2 people, and that's not really the point of it. So that time was blocked out for the whole team. And then we arranged a specific SCAPE meeting upstairs here, and we looked at the SCAPE document, and the blue one here, we looked at the previous SCAPE document and what points were highlighted there as points of improvement. And then from those points of improvement, we allocated specific team members to specific actions, and we found it a very useful exercise to understand what we needed to improve upon and what the standards were. Just refresh ourselves. Thank you. So there were some quick wins, easy ones that we sort of ticked off straight away. So in terms of mandatory training, which is essential for everybody who works in the organisation. We developed a data spreadsheet which was kept on our shared drive. All the practitioners and all the different sort of mandatory training that we had to attain. It was up to practitioners to fill it in when they last did their moving and handling, their safeguarding, their all the ones we have to do.
Yeah, the online courses as well.
And they become highlighted in orange or red as they're as they're gone overdue or going to go overdue. So that was a quick one, and on that as well is appraisal dates and revalidation dates, etc. We have a safety huddle in the morning, which the audit team praised us for. So rather than us all coming into work and then just dispersing off at 9 o'clock to see people, we come together in the office for 15-20 minutes. And we have a template for that, and I have it here. I think I only brought the one, but you might.
What we find with the team meeting every morning,
they pass it around there.
Address any issues that maybe are coming about, or from the following day. And if there's somebody within the experienced team we've got who can actually deal with any issues that any of our good practitioners have got. So it's
about safety, making sure that we know that if somebody's gone on maybe a risky visit or a visit that could be tricky, that they've got someone to buddy up with them. Somebody may have a safeguarding concern that they want to run past the team. Somebody might have a presentation to do in the afternoon and want some help with that. But we just come together and we have that sort of catch up and make sure that we're covered for the day. That we have enough medics so that the medics aren't overburdened with stuff. We might have stuff we want to run past Rahul and say, look, I'm a bit unsure about this prescribing issue, and it's just that time to kind of come together, and it's very useful.
I think it's been very good as well in terms of the team building thing for us, because previously we hadn't done that. And it's been very good in the sense of, I've got a bit of a quieter day so I can help you with that, and actually the team has done that, which I think has been really positive. It's like, sharing that workload if we know that somebody's burdened, and that it's been hugely positive, I think, for us as a team.
Yeah. And within that as well, we have a triage person, so that person is responsible normally for sitting in the office and addressing any stuff that comes through the door. So looking at it, so it's not left, so we can see actually this needs to be reacted to straight away, and somebody needs to go out. So that triage person would be responsible for either going out themselves or allocating somebody to it.
I think it promotes a little bit of transparency as well, doesn't it? With workload, we have to be transparent about what we're doing.
Yeah.
You got a question, Rahul?
Can I add that it's also a good place to vent out any frustration stuff?
So we do have a swear.
You have a nice little moans on the stage, or if anybody wants
get the moans out, get them out early. Yeah, and we can also ask about how the ward looks. We have 8 beds on Toltenay ward, and we may have somebody who is on the cusp of coming in. So how does the land lie downstairs, and all that kind of stuff, just to see what the day ahead is like. Then we established team leads for infection control, which was highlighted in the previous SCAPE audit. So I took on the infection control lead, and I go to those meetings and I feed back the sort of key points to the team on that.
We all take our rings off when he comes in.
Yes, they take off their big jewellery. You shouldn't have it on. And we do the hand washing audit as well, which is uploaded to the shared drive. I also took on the medications management lead, being the nurse prescriber. I thought that was the best thing. Neil?
I'm the safeguarding lead. I link in with Claire Linsell, who's the Oberlin safeguarding lead. She works with duty team. I'm also the first aid person. Although I'm one of 2 people for the Oberlin, so I actually link in for that naturally. And we work with people as well.
Yeah.
Safety, not safety.
She's the fire officer.
Fire officer, yeah. Fire officer.
Yeah. Another thing we did was we developed a documentation audit tool, and I've got one here with just a made up patient detail on it. So these are self audit tools. So we hold a caseload of people, and we're responsible for looking at that patient, making sure they have a care plan, that they have a generic assessment, that they have a risk assessment done, and we're responsible for ticking off that. It's quite a lot of stuff in it.
Keeping updates as well.
Just to make sure that we're doing good quality documentation. And then we have a weekly review of KPI data by the team manager and the PA, and that's discussed in the morning huddle as well, if those standards are beginning to slip.
Mm-hmm.
Okay, next slide please. Thank you. So on the day of the SCAPE audit then, we had service users and carers identified by the team, like case files that the auditors could look at and could either contact relatives to speak about their experience. They were put forward. I think we may have had, I don't know, 6 or 8 people that we did that with. We made sure that relevant feedback, which we weren't very good at, feedback from patients and family members that came in, that was it. So we had that displayed on our office wall.
And so back on the feedback thing, we've actually just done a new thing for that, for feedback for the memory clinic, to see what experience they've got from patients. That's just been done recently, in the last couple of weeks. We've just decided to do that. And that's
Yes,
that with our back and things.
that's a good one. We have a post-discharge, post-diagnostic follow-up pack, and in that is that how was your experience of the memory clinic assessment, because it's quite a thorough assessment. Neil drew up a list of important contacts that we might need in our work, just so we've all got our safeguarding leads and who the team leads are for infection control and safeguarding, etc. in the team. We established and put up the Charter of Care Values on display and filled in how we're trying to meet that in our way. And we just, try to be as welcome, open and honest and transparent in the work we do.
Mm-hmm.
Thank you. Next slide. So on the morning, the assessors that came, Sue and Jenny came, and they observed the morning safety huddle, as we do every morning. Then Sue met with our team manager separately to look at the evidence and how we were meeting the SCAPE standards. And Jenny came and met with us, I think it was us 3,
Mm-hmm.
and we just had a sort of, it felt like an informal chat when you were covering the stuff you needed to cover, and we gave evidence, kind of off the top of our heads really, about how we meet the particular standards. And I think we're fairly confident in that we knew how to do
experience
meet the standards, and we're doing it day in, day out, so it wasn't like we had to scramble and make stuff up, I hope.
I think alongside of this we are doing the memory service accreditation, for the MSNAP accreditation, and I think as well that has kind of informed a lot of what we do in the SCAPE audit, because we are kind of it's highlighted a lot of things that we now have brought into practice, hasn't it, that have then fed into the SCAPE audit,
very cost transfer,
which has been very beneficial, I think, for the team.
Quite a detailed audit of our practice. And we're hoping to try and meet that standard and get accredited. What else have I got to say? Where are we? That one, I think I've said everything on that. I think, So reflection on the whole process. We felt prepared because we'd done the preparation work beforehand, and we'd looked at the document. We knew who was doing what, and it didn't feel like a pressurized process. We were ready for it. We got positive initial feedback from the assessors that we seemed to be a very cohesive team and with good morale throughout, and we're very supportive of each other.
Mm-hmm.
And and then there was some additional evidence also that we reflected well on the team, such as clinical pathways, which we have developed here, how to refer into the team, how GPs should refer into the team. We're about to present K&I to the GPs this week, Thursday, about, you know, making good referrals to memory clinic,
Yeah.
because
We
this,
do-
this slip.
Yeah, we do find that sometimes they don't do the full pathway like they should do, and then she end up with paperwork bouncing backwards and forward, and it just takes up a lot of time that you didn't really need to take up. And then sometimes they'll only get half the bloods done, and then they have to contact the person for another appointment, then they have to pay them £50, and then it carries on, it just, little things
It's,
like
it's
that.
trying to standardise referrals really, and
Yeah.
make sure that for patients that their assessments are not delayed,
Yeah,
which they can be by lack of a thorough assessment by
yeah, physical assessment, yeah.
GPs. So we'll see how that goes then.
We have, you know, also that was reflected back to us as good practice. We have regular good clinical supervision booked in with our team manager, who goes through all our caseload and say, how are you getting on with this person? What's happening with them? What's the plan? Are you going to discharge them? Are you going to keep them on forever?
Neil.
What do you mean? Then we also have sessions with not the clinical lead, the development lead, Kat Phillips. I have a session with her just to bounce off some ideas, a different experience to what these guys have got. So it gives me an idea of a different plan of attack on certain situations as well.
Mm-hmm.
So.
And I also get an additional supervision session with our previous consultant for prescribing issues in particular. So that was reflected back on well. Also, next one, conclusions then. So we found that good communication involving all the team in the process was essential, so that we're all involved in the process and all coming from the same standpoint. Being prepared and ensuring that safer care every day is embedded in the heart of everything we do. So that's what the reason behind it is. And that we should encourage individual team members to come up with new initiatives, focusing on improving standards. So for example, Sue and I and Kirstine next week will be starting a cognitive stimulation therapy group. So this is a group for people who have been recently diagnosed with dementia, milder dementia, who will take part in a group of maybe 8 people, and we're going to run it for I think 6 or 8 weeks? 6 weeks, a 6-week course with 8 people, doing groups about using reminiscence, quizzes, interactions, music to try and keep that brain stimulated, and that'll be a first for the island really. So that just came out of an initiative within our own group. And also we're going to look at, I've started looking at antipsychotic prescribing. So I've written to the GP practices to see, can we get an idea of how many older people out there remain on antipsychotics, and then we can look and see, was this a sort of a historical prescription that maybe they discharged from hospital on some risperidone and that they should have been taken off. So that's another thing that's going to happen in future.
Yeah, we're keeping a note, each NDT that we have each week, we're keeping a note of anybody
Yes.
who's been newly prescribed antipsychotics, so we can keep up with them, and just like you said, just to see if we actually need them at this moment in time and when we can get them off them.
Yeah, so stuff like that, because there's been a huge amount of work done in the UK about overuse of antipsychotics, and people have been left on them for long past when the problem has already gone, so they should be taken off as soon as possible. Last slide I think then. Yeah, that's it. So conclusion and learning points, focusing on our KPIs and reviewing those regularly, and ensuring adherence to those KPIs and monitoring the outcomes. So Mark is keeping up on top of that. Respecting each other as a team, respecting each other's values and differences. We're all individuals, but respect should be the key part underpinning within a workplace. And for a process like this, not leaving everything to the last minute, and ticking off quick wins along the way has been really helpful, so it's not all done on the last week. And the last thing we said was that we should be proud to be part of a team that focuses on giving the best care, and Mark had put in, would I like my mum to be come through this team if she was referred, and the answer should be yes. So that is us.
Any questions?
Yes.
One thing that struck me throughout your whole presentation was how embedded the MDT is in your focus on SCAPE. And it's something in acute that is very much a nursing focus to this SCAPE. And so have you got any tips for us in acute on how we can engage our wider MDT in SCAPE?
Have a morning huddle.
Yeah, that's it. And invite people in and invite different people. We have like GAA like come, and the different external groups will come to some of the meetings we have, just to get an idea where we're at, and then they can probably help. They've got an idea of what focus we're looking at and things.
But yeah, I think
So I'm inviting other teams from other different places at OT. So
we're lucky that we have, you know, Rahul's been with us for a long time, so he's very much part of the team, you know, and doesn't really kind of sit outside it. So he is part of the team, and that's been helpful, you know. So the morning get together is good.
And I think within mental health in generally there's no hierarchy as such. Everybody's on the same path. So you've got your support workers just as valuable as what that always in a roundabout way. You get a lot of say. Well, you know what I mean? Everybody's on a path. There's no hierarchy. And then all that side of things.
As long as I'm on your place.
I think it doesn't help like we have like we have pizza days, we have like regular other stuff happening. So you have to make it sort of more inclusive as well. So sometimes
we have pizza days and stuff like that. Yeah, they'll get pizza.
I remember when the huddle was first talked about, and you know, as a team we were quite resistant to that. We were too busy. We've got too much to do. We can't possibly spare half an hour in the morning to kind of go through things, and it was kind of a real challenge, wasn't it?
There was a bit of resistance from some people.
Once it started, it was, you know, it's become now embedded in kind of what we do, and it, you know, and it has been incredibly beneficial, and the doctors come to that when they can. So that's kind of made that MDT more of a multidisciplinary team as opposed to that kind of division, I suppose. And I know that's not always easy, is it, to kind of do that, but certainly start somewhere, you know what I mean?
Yeah, and generally like on nights out and things, everybody seems to go. Night outs? Yeah, so everybody seems to just enjoy it and just go out, so it seems to be a group activity at all times.
We're too old for that.
Yes.
I was just thinking in regards to the MDT, I think it's because you are an actual team that includes an MDT, whereas I think as an OT, we're an OT like we're an OT service and the speech language therapy service, and the physios have done theirs all separately. So it's sometimes where you live and people are going all over the place. They don't sort of see their home as one place, so it makes it difficult to attach yourself to a unit or attach yourself to a group of staff. I think it'd be great. It'd be nicer if it was more.
There is significant work done to try and ensure that no matter if it's Vic Wing, SCAPE or Careys or Brock, that multidisciplinary team is part of that process. And you, allied health professionals, might have your own SCAPE. For example, GTG have got theirs now, but you can also potentially affect the outcome, or you will affect the outcome of Victoria Wing or whoever else's SCAPE if you're not adhering to that process as well, and do something that potentially jeopardises their outcome, which has happened on several occasions actually, and the wards have felt quite frustrated, and I think sort of probably some of that is what sort of Claire's sort of saying there, is how do we embrace that multidisciplinary team to sort of take on SCAPE as a whole, as being we're all part of that process. Maternity are working on changing their tool, and very much have thrown ownership back to the obstetricians and gynecologists, who are at the moment quite positive about, actually no, this is ours as well, we need to do this. So it is doable. It is part of just trying to find somebody in those MDT groups who is interested, who values SCAPE, and maybe comes along that journey with you. It is doable and it is possible, and it is very much, we don't separate them out, to be perfect. You know, when we come and audit, they are very much part of that process, but unfortunately perhaps sometimes they don't quite see it the same way, but we spend a long time chipping away at those links.
And
it's of course, it has been mentioned before today. SCAPE started as a nursing assessment process, so it's still, especially in the acute, it's still very much hospital-based and nursing practice-based. However, we have been trying to change that, and we actually have even changed the nursing core standards as they were known until last year, I believe. Now this year they are just the core standards, so we lost the nursing bit. That doesn't necessarily mean that the standards themselves won't still just reflect on nursing work and not the MDT approach, although we do as auditors try to do that, but it's not as straightforward as it should be, and it's not only due to the audit tool itself, but how some teams work and how some teams have been used to do SCAPE and have SCAPE as it's just the ward and just for nurses and HCAs to be involved in that. So we do need to change that approach, and we do need, because we have had from the other SCAPE audits we have been doing with the physiotherapists and cardiology and all of that some communication channels need to improve. So that SCAPE might be the starting point for that, just to have everyone communicating and speaking the same language. So when, for instance, Jane mentioned they have meetings, and I know that this team has as well, meetings just to discuss SCAPE standards and how they are regarding SCAPE standards. So if you actually invite more people, in this case from medical and surgical wards, invite OTs, dietitians, whoever might be relevant to that particular meeting, if you are invited to that, potentially we might be able to actually start having those conversations and start changing the tool to make it more MDT approach. I would say that. Yes, Claire.
With the move towards the electronic records, is there scope within SCAPE to have standardised forms, or is each sort of area's SCAPE have their own forms and their own way of doing things? Are there multiple different audits, or are there generic audits? I'm just thinking, so does each team have to reinvent the wheel, or are there things that you can take and...
Like the note writing.
I think what I understand is there's a baseline.
Yeah.
And then, because each team, like my team is a community-based team, so there are some aspects of ward care, for example, would apply to us. So we do tailor it, but I think there is a baseline scheme for it too.
Exactly. It's exactly just like that. So we do have the core basis of SCAPE as an internal audit program that goes across every single service area in the organization. But then, of course, we need to adjust that to the quality standards that are relevant to OTs, to speech and language therapists, to physiotherapists. So we try to do that as best as we can, and inevitably you'll have some differences. But regarding what, for instance, documentation audits, we try to standardize as much as we can. At the moment, some of you might be aware, we have what we call HSE audits on SharePoint. And some of you might be involved in that. We have the hand hygiene one, we have the drug chart audits and documentation audits. This year, the documentation audit for mental health services has changed dramatically in comparison to what the acute are still doing, because it is different for them. And they are, most of the teams in mental health services are already using electronic patient records, although it's still tracked and it does have a few limitations, but they're already using it. So they were still using an audit tool that was very much paper-based. It didn't make sense to them to keep using the same standards, so it was dramatically changed for them. So we might still have that, but hopefully we'll be able to have, for hospital-based services, just one form for documentation audits, for mental health service, a different one, and ADS, and just like that. So we will still have a core process that will be common to every single service area, but there might still be some differences because services are different. So nursing notes are different from service to service, so we need to adjust to that as well. But we're trying to standardize it as much as we can. I believe we both attended the HOP meeting today, so we've talked about how the new EPR systems will help with audits and will help staff prevent all the extra time they need to take with all those spreadsheets that I've been supporting staff to set up. So yes, we are trying to have that as just potentially a maximum of 5 common forms, common structures, whatever it might be, to every single service area. So we are not doing different things and not reinventing the wheel for sure, because we don't want that. We cannot afford the time to do that. So.
And that's very much what Safer, one aspect of what Safer Every Day is all about. It is all about ensuring that we standardise processes, we standardise practice wherever possible so that we know care is being delivered safely, it's good quality, it shows improvement. So that, you know, SCAPE embraces Safer Everyday, embraces everything that actually will lead to an organisation that will deliver high quality care. So yeah, we continue to challenge when we see things that are not standardised. We continue to challenge when we see someone who says, yeah, but I want our document to say, I don't know, Victoria. I'm going to use Victoria Wing, not because they do that, but because they've been here today and I can use them. Victoria Wing, even though it, you know, doesn't need to say that at all, it can just be the same tool. Yeah, we need to stop this behaviour, and we are slowly chipping away at that as a big piece of work.
Why our team and now Professional Alliance are trying to promote SCAPE across the organisation so badly, because it's one way of actually being able to standardise those processes for everyone as much as we can, because it's the common link between every service area if you have them in everywhere, isn't it? So yes, that's what it's, and thank you very much for your presentation. Another fine example, and I have had the pleasure of witnessing the positive impact that SCAPE has had for you. So I just have a very quick question. You have very kindly mentioned how the informal chat we have actually potentially helped you throughout the process. Are there any suggestions, anything that you think we might need to improve from a SCAPE auditor's approach to the process being still so recent to it?
I can't think of anything.
No.
I don't think there's anything. I think the engagement is quite good from your side.
No.
No, it was fairly clear. There was no surprises really on the day, and you know we.
I think by doing it that way, it helps to actually get information from people rather than being so formal.
I think, and also the kind of prep, it's about, you know, I think a lot of people hate audit, don't they, because all of a sudden once a year it's looming, isn't it, and oh my god, and it's kind of like there, it's there. And I think the prep stuff that, you know, that Mark did was doing behind the scenes, obviously that kind of paves that pathway, doesn't it? That actually means we know what we need to do, we know what we've got to kind of achieve, and that kind of makes it less of that scary, oh my god, it's audit time, which...
And everyone was involved, so it was... Everyone had a key role, you know, and it might not have been your role in particular, but I knew that, you know, Kay was doing that part, so you could hand you over to Kay, who's done that bit of it, you know, and so it was spread out well.
Good, thank you.
Okay.
Well done.
Yeah.
They are very short questions. The first one is, how did you overcome the resistance when you initiated hurdles? When you started doing the hurdles in the morning, how did you overcome the resistance?
It was overcome by our manager just saying we're doing them. We're doing them. So after a week, it felt less like a roll call than a useful time.
Because what it does is, if you're feeling like I can't do this because I'm really, really busy, and then actually someone says, well, I can help you out.
I've got some spare space.
So actually, bizarrely, although you might be still going to be as busy as you are, it might be, well, I'm a bit quieter today, I'll help you with that. You know, especially things like our triage days, for instance. If I've got quite a day and I know, say for instance, Sue or Sarah are really busy, I'll go, right, if something comes in, I'll pick it up for you. So actually, paradoxically, just taking that 20 minutes means actually that other people, it's transparent, we know how busy people are that day. So, you know, in a way, then you step up and you help.
For the stress, unnecessary stress that you don't need.
Whereas you're not sitting there kind of going, well, you know.
Because everybody's not the same wavelength as well.
No, that's
generally. And I've said it before, it's the best job I've ever had, actually, this team, because they're so together.
Any other question?
Yeah, and yes, the second one, because our team is almost similar to yours, because we are community based. Did you initiate dialogue with the quality and safety with regards to the standards appropriate to your service, or did they come to you?
They were arranged with Mark and the team, I think, as to what ones we'd be audited on. So yeah, I mean, a lot of the clinical elimination ones and that kind of stuff, and we're taken away because I don't think it would be fair to audit us on elimination because we don't monitor that for people. You know, they're in their own homes, and and they're usually not clinically unwell. They're you know, it's a mental health issue. So you know, skin condition is not usually a ornament. These kind of things were taken away because yeah, we just don't do them anymore.
Thank you very much.
Okay.
Does anybody else have any other questions? I haven't got any on Teams so far. So I would just want to say thank you to both teams for presenting. Very different approaches to how you go about doing it as well, because whilst there's, just to be clear for those who perhaps are more experienced in the acute way, where it isn't known when you're green when you're going to be audited, although some people can work it out. You know, that what you're talking about is just sort of that period of time of sort of making sure we've got things in order, because trying to do auditing a team that is like yours, of which there are many similar, you have to have some preparation, because you do, as you say, you can't all be out visiting your service users, because we need to ask you questions, and there is a little bit more planning and logistics that do need to be taken into account. But that doesn't make your audit any less valid. It absolutely makes sure that we're looking at the right things and asking the right questions and seeking the right responses as well from the service user groups that you're involved in. So I think it's been a really positive approach, although it looks quite different to what the acute hospital would be more familiar with. So I just wanted to sort of flag that. Safer Every Day for the next event is. Oh, yeah. Sorry, I thought they got one. Sorry. Apologies for that. Yes, thank you. Safer Every Day. Oh. Yes. What I'm going to do, can I ask you, Paul? Yeah. Can you send me those electronically?
Yes. Yeah.
And then what I will do is I will send them out to everybody who's been at the session and on Teams, and then you've all got them. Regarding your session with the GPs, I had thought perhaps you might want to pick up an opportunity to use one of my QI clinics and record it, thanks to Ollie, which then means we can perhaps just share it out to a wider group of doctors on a regular basis about what you're trying to get. Okay. So maybe that's something we can talk about separate today. Safer Every Day. We've got continue to have monthly QI clinics, but I will just say the QI clinic set for April will not be going ahead. So I'm going to have to unfortunately cancel the April session, which was on the 11th. The 16th of May, we are hoping that we will be able to share a bit more around the policies and procedures and guidelines work that we are trying to do. For those who know, we've not been very good at keeping our policies and procedures and guidelines in date across HSC, and we really are, we've got to get this sorted, we've got to get it right. So there's a big piece of work going on at the moment. There's going to be a new environment where policies will be hosted. Most people will have known Poly Plus. That is going to become the policy portal and will be accessible via Livewire, which is the replacement of the bridge. It's all going to be in a SharePoint arena. All these words, they come out well, but I don't understand them all, not all of it. But what we've seen and how that's going to look, it's going to be phenomenal. It's going to be really good, actually, and I think it's a really positive, dare I say it, about policies. It actually looks really quite exciting. So that's a piece of work we're hoping to do, and hopefully we can share some of that in the session at the QI clinic on the 16th of May. If we can't, it will be because, you know, there's still quite a bit of work to do, but I'm hoping we can do something by then. The actual presentation session, next one, is the 8th of June. Again, volunteers very welcome. We've got some thoughts, but we still have not confirmed anything as yet as to what's going to be presented and shared. But it's a great opportunity. There's some work that your team are doing that, you know, I wasn't really aware of, and I'm sure probably others in the room aren't either. And you know, I'm already thinking, how do we know? How are we going to measure that these things that you're doing are actually making the improvements and the difference that you hope? And I'm probably fairly confident will. But how do we do that? How do we demonstrate, and how do we share it? And Safer Every Day is a platform that you can do that. So not only have you come to talk about how you got your SCAPE audit process embedded, but you could come back and feed back those improvements that you've seen through those changes that you make in practice. So I'm kind of hoping that might happen, to put you on the spot again, and come and share some of that good work over time. Obviously, I'll let you get it. That would be, I think, it'd be really good, because you know, I think dementia is something that we all have probably close to our hearts. Either we know somebody, or we have, you know, family members, or we have concerns possibly for family members, and I think it's something that we can probably all take something from, and either be reassured or comforted, or equally be challenged to think, what do I do next? So yeah, okay. Thank you very much. If nobody else has got any questions, you are very much free to go, but thank you for your time.